enlightening us about Partograph, because it is highly essential, it is important, it is pertinent, it is highly crucial in monitoring labor. Without Partograph, it might be difficult for us to know how to summarize labor specifically. Let's talk about the definition of Partograph. Partograph simply means summarization of labor. It summarizes labor in the sense that assuming cannot see or document whatever the woman is passing through in labor, mere holding a Partograph will be able to summarize everything, starting from the name, gravidity, the parity, the hospital number, dates of admission, the time of admission, the states of membranes, and the hours. So, my definition for Partograph simply means summarization of labor, as I earlier said. So, it's been divided into two main parts. We have the fetal part and the maternal part. The fetal part is above, while the maternal part is below. So, let me run through the headings. You write the name of the patient, date of admission, time of admission, gravidity, as I said, and the state of membranes. How are you going to know this? You have to ask the patient about the states of the membrane by asking her a simple question: have you seen water? That is the layman's word. The patient will tell you yes or no, and you still have to know the hours. And what is the implication of this? The implication simply is basically for you to know if the patient will need antibiotics or if the baby will be admitted in the neonatal ward. So any pregnant woman that ruptures the membrane within for more than 24 hours, the mother must be given antibiotics and also the baby must be admitted to the neonatal ward. And to start from here, this is 0 hour. You've asked that about the time of admission. For example, what's the time now? My time says it's around 11. So 11 a.m. That's 0, 1, 2, 3 hours. And you write the time here: 11 a.m., 12 a.m., 1, 2, 3. So this signifies 1 hour, while these tiny lines signifies 30 minutes. That is that. And you should know that these alerts and action is communicating something to us whenever we are monitoring labor. A normal graph should go towards the side. It shouldn't be falling down. If that is happening, you must act. And whenever it's going like this, the alert is telling you that you must get set for your patient because you can deliver at any time. Meaning, you have to get your instruments ready, you have to mount NDC for your resuscitator to resuscitate the baby, and some other things you have to put in place. So she comes 11 a.m. The contraction, this is where we chart for contraction, the drugs and all of that. So when she's around, you know, it's very important while monitoring labor, the FHR, what is FHR? That's fetal heart rate, is very essential. Because there is no way you can tell a pregnant woman that has been carrying her pregnancy for like 9 months. For her to deliver, you now tell her that you cannot put the FHR. Nobody will take that from you. So monitoring of FHR should be done every 30 minutes. And it's very crucial. While checking the FHR, you have to listen to the rhythm, the strength, and the duration. If there's any disparity, you have to act. You have to raise alarm to know what to do to prevent such, because the FHR could be bradycardic, it could be tachycardic, either of the two. The normal range is between 120 to 160. Anything below, you have to act. Anything above, you have to act. So, assuming she comes in 11 a.m., as I've said, the FHR she came in with is 140. Just put a dot. 140. And everything must align. But another thing, major mistake that I've noticed, majority of people that have gone through their Partograph, even if the woman is 6 cm, they will start from here. That's very wrong. 4 cm will be here, as I've said. 5 cm will be here. 1, 6 will be here. 7 cm dilated. 8, 9, and 10. So it's not as if just try to anyhow that 5 cm start from here, the way I've explained. That is how it should be. So if it's coming in 5 cm, you just put asterisk this way. And the station, station simply means the relationship of the presenting parts with the ischial spine. That is station. If the presenting part is at the level of 0, that is the level of the ischial spine, that's station 0. And you plot it by 0 dots. So anything above 0 is minus. Anything below is plus. So station 0 is at the level of 2. If it's minus 1, it's at the level of 3. If it's minus 2, at level of 4. If it's minus 3, at level of 5. So anything plus will be beneath station 0. So you plot it here. And I know by this time, when the presenting part is at station 0, the baby must have been delivered. And you now go through the contraction. You're going to know that you have to monitor the contractions for 10 minutes by placing your palm on the fundus, not just on the abdomen. It should be on the fundus. The implication of that is the peak of contraction is like a wave that comes and starts at the level of the fundus. It radiates laterally and it goes down to the pelvic region. So it's better you place your palm on the fundus whenever you are counting contraction. And there must be a time, a stopwatch that you must be checking because you are monitoring for 10 minutes. For example, if she's contracting 2 in 10, lasting 20 or 30 seconds, you'll be checking your time to know all those. And we have ways of documenting or charting it. If the contraction is not so strong, let's say she has 2 in 10 contractions lasting 25 to 10 seconds, you know that you have to dot it, meaning it's not strong. Let's say it's between 35 to 40, you stroke. Let's say it's from 45 to 50, 60, you shade. Am I communicating? You shade. And we go to augmentation of labor. After monitoring the labor, you realize that she's not doing well, she's not contracting. You have to do something, and this must be done based on your knowledge as a midwife. You have to know her parity. You have to come back here about her parity and her gravidity. Let's say she's like gravida 5, multigravida, cannot just augment, although you can, but it will be done consciously. You cannot compare the way you are going to augment the primates as compared to that of the multigravidas. You know, the uterus that already carried over, so you have to be careful to prevent uterine rupture. So what you want to augment for multi, you use 2.5 international units, because oxytocin comes in international units. Use 2.5 international units, added to 0.9% of the normal saline, and it starts at 10 drops per minute. And that must be closely monitored. It must be closely titrated, because whenever you are monitoring the next 30 minutes again, after you started the augmentation, if she's doing well, you can maintain it at 10. If she's not doing well, you can increase to 20. You'll be doing it at interval. And whenever the contraction is at the peak, let's say she's now having like 4 in 10 contractions lasting like 40 to 45 to 50, you can leave it at that level. And let's say primigravida. A primigravida means someone that has not been pregnant before. These are first time. The uterus is still brand new. In that case, you can use 5 international units that will be added into isotonic solution. Use isotonic solution like 0% normal saline. You add 5 values to that normal saline. Start with 10 dpm, 10 drops per minute. And after 30 minutes, she's not doing well, you increase it to 20 drops. After another 30 minutes for palpating for contraction, she's not still doing well, we increase to 40 till it reaches the maximum drop. The maximum drop is 60. Anything that goes beyond 60, you cannot increase further. You leave it at that level. And you must keep an eye on the healthy child by monitoring it closely. Let's go to the any job that's been given. So it will be charted like 5 international units. the drops, 10 drops per minute. And everything must be aligned. I've said that before. 4 cm like this, 5 cm, everything will go downwards that way, and 6 cm, you start your clothing here, and it must align. And going to the drops, I said a lot of times about the membranes. The importance of membranes, whether the membrane is intact, it has been ruptured, either spontaneous, artificially ruptured by what's it called? Can use hookers, can use a nail hook, either of the two to rupture the membrane. The membranes are still intact. But let's say she has ruptured. You still have to indicate here SROM, spontaneous rupture of membrane. Let's say artificially ruptured, you indicate HARM, ARM, artificial rupture of membrane, and you note the hours. Timing in labor ward is highly crucial. You have to note the hours that is being done. Another thing, let's say the membrane, after it has ruptured, either you are dead or not. So you have to have the patient, the color of the amniotic fluid, either dead, meconium stained, or bloody. Let's say it's clear, you indicate by writing C. If bloody, write B. If meconium, write K. Is that okay? Another thing about the drugs, you also have the patient that, assuming she has ruptured before she came to our facility, you give antibiotics, something beyond 24 hours. And parenteral antibiotics must be given. Antibiotics like efferoxime will be given to the patient. And you have to document it here. You write the dosage. IV efferoxime, 750 milligram, IV, and with timing. Is that okay? And let's say at times we love to manage pain in labor. You know, pain is not something palatable. Pain could be so detrimental, and don't want our patients to go through to feel pain to that extent. So at times they could be given paracetamol, they could be given Surex, IV paracetamol to administer. And at times the epidural also is being encouraged. So we also encourage our patients to go for epidural analgesia. So after the vital signs, we don't joke with vital signs of any patient, because as the name implies, vital signs mean it is vital, isn't it? So we check the vital signs, the temperature, the pulse rate, the respiration, and the blood pressure. And all must be well documented, because anything that is not documented simply means you have not done it. So this is the chart for blood pressure. Let's say she comes in with 120 AC, just put an arrow this way, 120 AC. Pulse rate of 100, you indicate. Respiratory rate of 58, you write beneath, seconds per minute. The temperature, you document it, 36.4, you document. And even urinalysis is very important. Protein, acetone, and the volume. If you are, let's say after checking the urine and you discover that she has like 2 or even 1 plus of protein, you have to act. Meaning you have to go back to the blood pressure and see and check whether she has edema. If there are those signs, means she's tilted towards, or she has already been diagnosed with preeclampsia, and that will not be taken with levity. You have to take further investigations. You have to really keep an eye on her so that she will not deteriorate or depreciate to eclampsia by throwing fits. We don't want that at all. So the volume too is very important, because you have to measure how many mils by using a measuring jug. You measure it. If it's 200 mils, you write it there. And also, I always tell my people and even my students that it's better you use the measuring jug so that you can easily know the quantity. And you also check for the color. If it's concentrated, if it's body, all those things are communicating something to us. If it's concentrated, it could be that she's dehydrated. You just need to rehydrate her with IV fluid. If it's bloody, you know what to do, whether the bladder has been traumatized or the labor is being obstructed. So all these things are very essential as a midwife. So afterwards, you have to be monitoring everything and ensure it is well plotted. And at the end of the day, she now delivers. You have to write the summary of labor here. After delivery, you write, she progressed to SVG of a live female or male unit at so time. You write the full length, the circumference, the birth weight, the summary of the labor, just summarize towards this side, and write the sex of the baby, the HAPCA score. So it's highly essential. So without Partograph, there's nothing you can really do, and that can easily differentiate us from the quarks. Thanks for listening.